Good morning. Esteemed guests and respected colleagues, it's a really great honor for me to welcome you all to this important event, the EU Beating Cancer Plan Closing the Gap in Cancer Care in CE and Baltics. Well, we have a special emphasis also today, and we will talk later on about multiple myeloma, but we will definitely come to that. Today, we come together to share knowledge, discuss the new ideas, and work on solutions to improve cancer care. We have experts, professionals here from really many countries, and your experience, research, and insights are really highly valuable to us. And hopefully we will learn from each other, explore how we can make better care and reality for every patient. Let's use this time to build strong partnerships and plan effective actions, and together I think we can make further difference in the fight against cancer. So thank you for being here and for the commitment to this cause. Let's have a productive and inspiring event. So welcome once again. It's my privilege to give the mic to the Deputy Minister, Mr. Jakub Dvořáček, from the Ministry of Health of Czech Republic, and asking for the couple sentences at the beginning.
Couple sentences, okay. I will try to be really fast. First of all, thank you. It's always a big pleasure to work with Professor Bábela. It's from our time, where we really worked closely, during the Czech presidency, and the oncology was really the high topic, for the Czech presidency all the time. It was great to have the expertise, from you. So when the invitation comes, I respond, and I believe, the oncology is the area where we are doing quite a big progress, and the European Beating Cancer Plan is like a red line, which could be used, for all of us, to set up a good benchmark, to set up, let's say, the vision, and from which comes, the national plans and implementation of all the steps, in this important area. What I would like to mention it, and as you said, it should be, just a couple of sentences, is the continuity. And I have to say the Czech Republic is quite lucky that we were able to build on what the previous government did. And of course, there were changes. Of course, we did a lot of adjustments. But the core of the National Recovery Plan investment remain. And we even built it, the further funding, for the oncology. And I have to say, when I see, how much money flows, in the Czech Republic as investment to the new centers, to the building of the comprehensive cancer centers, in Prague, but also in the regions. When I see the investment to equipment, to very expensive screening systems and diagnostic tools, it's a very nice time, and we have to. And we should, I mean, the Czechs are well known, that we are always complaining and we have always, not enough. And but on the other hand, if I really take, everything what was done and what is going to be done, what is going to be implemented in oncology, we have a good times. We have a really nice times, for this therapeutic area, and I believe, it will continue as long as we will know what we want to achieve it. And I think, the vision is there. The Oncology Society in the Czech Republic is doing great steps to move the whole therapeutic area forward. And you know how it is, we are in the region of Czech Republic, Slovakia, Poland, Austria, and we always benchmark each other. We always try to see, what we do, in those countries. And you know how it is, we always try to be a little bit better than the average, yeah? So I hope, and I think this is quite same, in Slovakia and in other countries in our region. So let's use this small competition as a good tool to move the oncology forward. And yes, we have nice tools like European Beating Cancer Plan. We have national plans, and I have to say, when I see the access of patient, to the very innovative therapies, it's getting better. we have a lot of disparities, in the access to the care in the regions. There is a lot of things which needs to be changed, but we are in a good track. That's my feeling. So thank you for this event. Thank you for the chance to be the part of the discussion. And looking forward, to get the ideas. We can move it forward.
Thank you. Thank you very much. So you saw the Slido sign. So before we start the first panel, please try to log in, and you can submit your questions. All of you, including the people who are watching this online. So, ladies and gentlemen, I'm pleased to introduce our next and first panel discussion titled EU's Comprehensive Approach to Tackling Cancer. And this panel will delve into the EU mission of cancer as an integral component of the European Beating Cancer Plan, and we will try to explore its current challenges, maybe funding opportunities, and significant projects, as well as the pivotal role played by the European Parliament. Our esteemed panelists are not all of them which supposed to be here, but anyhow, at least 2 of them are with us online. Hopefully they will bring diverse perspectives from various sectors. So I am honored to have Deputy Minister Jakub Dvořáček here with us, Michal Štovko, State Secretary at the Ministry of Health of the Slovak Republic, says hello, but he couldn't be with us today because he's at the Parliament defending the budget for the healthcare today for with the members of the Parliament and Ministry of Health. But I am also privileged to have Radka Maxová, member of the European Parliament and a part of the Subcommittee of Public Health. Hopefully she's there. Welcome. And then Professor Svoboda, board member of the EU Cancer Mission and director of the Masaryk Oncology Institute. Welcome, Professor. And lastly, but not the least, Sonia Čierníková. She's representing Slovakia and National Oncology Institute in Slovakia, and she will hopefully provide a vital perspective of cancer and management at the national level in Slovakia. So we can start, and I will start with you, Deputy Minister. When I was preparing the questions for the discussion, they are very tough. Well, the 3 areas pop up to my mind, and there was maybe the cancer integration, the mission integration on the local level. Then there was the challenges and opportunities, and also the cross-border collaboration. You mentioned the competition in a good way, but
I meant collaboration.
well, we all the time when I was at the Ministry of Health, we used the Czech Republic as the benchmark, so it's good to have the neighbor who is better in something, and we could use and to improve ourselves. So I think it's a good way how to move forward. So what do you think, how is the Czech Republic integrating the EU mission of cancer into its national healthcare policies and cancer treatment strategies? What is your perspective on this?
I would say, this question flies much better to Marek Svoboda, because Marek is really, the guy who is pushing, a lot the development of the oncology here in the Czech Republic. And Masaryk Oncology Institute is really the flagship of our movement forward. And I believe, that through this, through his mission, and also the other colleagues, from the Oncology Society, we are closely interconnected, with what's happening in Europe, what's happening under the umbrella of European Beating Cancer Plan. So, to answer this question, yes, I believe, we are moving in a very positive way, but I think Marek should be the guy, to answer this question. if he see, our movement, the positive enough or let's say stagnating. But I really see, from his side, a lot of activity and movement, in this field. So we are lucky, we have such a representative, in European structures, but also, pushing here in the Czech Republic. And you can say, okay, it's not about that everybody is replaceable, everybody could be changed. But I believe, that thanks to Professor Svoboda and his work, we are really lucky, and it's not everybody is at the end replaceable. So, I mean, that's showing, that one person can really change a lot, the things around and in the environment. So maybe Marek, you could build on that.
Thank you so much to the Deputy for the introduction. And first of all, I also would like to thank the organizers for the invitation and the opportunity to speak at this prestigious event, because the topic is really very interesting, and it's actually true that there is some kind of gap in cancer care in the Central and East Europe and Baltic countries, comparing the North and the West of the Europe. And there are many reasons for that, and some of them, of course, the burden of the risk factors for the cancer. Some of them could be how we are organizing the cancer care. And a very important cause of these discrepancies also that I think there is a big problem that there is a low participation of the public in the oncology screening programs in our countries compared to Western and East and Northern Europe. So what I want to say, and this is something what colleague Dvořáček said, the Czech Republic is really starting to break away from these trends. And there is now significant decrease in mortality from cancer disease in Czech Republic, and it's much faster comparing the EU average, for example. And I think it's thanks to the good organization of cancer care and prevention and screening programs, and also the spending on oncology. And however, we see that in 2023, the cancer will be the most common cause of the mortality in EU. So that's the reason why we are trying to implement the Europe's Beating Cancer Plan to our national policies and to use the maximum amount of the resources coming from the European funds to support the cancer care system. And if I will go to detail, we, for example, published last year, and it was approved by the Czech government, the new National Cancer Control Plan, which will be valid until 2030, and had many actions, and about 7 of those actions are synergic with the Europeans Beating Cancer Plan. And also we are using the money coming from the European funds, different sources, different financing instruments, which is now offering the Europe. And the Europe is offering it because the Europe has the European Beating Cancer Plan. So most of these financial instruments dedicate the funding for the cancer. And now, as colleague Dvořáček said, it's about 480 million euro, which will be invested during the next 4 years to the Czech cancer care system, mostly to the cancer care, and some of the money will be also invested and are started to be invested to the cancer research. So we can discuss in details later on, but this is the one way how we can really escape from the fate of the Central and Eastern Europe. And I think this is a good way. And that's also the reason why the Czech Republic is mentioned as a positive example of best practices for the other countries by the European Commission regarding, for example, of investment from the National Recovery Plan and EU React to the Cancer. I think I said too many things at the beginning, but we can go in details later on.
Thank you very much, Professor Svoboda. You mentioned the recovery plan, hopefully also in Slovakia. We will have a chance to use it for the National Cancer Plan. But comparing the 480 million euro compared to 4 or 5 million euro, which were allocated for National Cancer Plan in Slovakia, we have a really good benchmark, to be honest. Maybe one more questions for you, Deputy Minister. Challenges, opportunities from your perspective when we look at the European Cancer Plan on the national level, because this is something which each nation, as I understood it well, should take a look and maybe implement in their own ways, So it should be something. It should help you, to implement the cancer plan. So opportunities, challenges from your perspective at the Ministry of Health, maybe.
So I will again build, what Marek, Professor Svoboda said. Yes, we have already quite a good organized oncology care. Yes, we have already quite a good capacity. But still, we struggle in some of the regions. So, yes, if you're living, for example, in Karlovy Vary region, your chance, for let's say access to treatment, the speed of the diagnostics and screening, and all those things are incomparable with, for example, city of Prague or city of Brno, and those places which have a much higher concentration of the capacities and so on. So yes, we have a struggle to have equal access in all regions. So the investment also supposed to come, to this area to build it a better connection, better organization of care to really ensure that the people get the same access also in some of the regions which are not at this moment fully covered. And the second, what was mentioned also by Professor Svoboda, we could have a number of screening programs, millions of screening programs, but if the people will not come, it will be only good for presentations. Yeah. So what we have to change is the way, how to motivate the people to get to the screening programs. And I think, this is a step which we are now going to take, and I believe it will come at the beginning of the 2025, and it comes to our payers, to the insurance funds, and their responsibilities and duties and possibilities they can offer to their insurees. And I believe, that we are going to deliver or deploy the change which will allow the payers to be much more active in this field. They will be able to invest much more money to this field, to create the motivation schemes for the patient in higher scale. And yes, this is why we have the insurance funds. They just shouldn't be only for reimbursing and paying for the care, but they really should deliver the activities, the programs, the steps, which will motivate the people to come. And we will give them this tool, and then we will try to motivate our payers, to motivate our patients to come and to use what we are creating for them. Because I believe this is a great opportunity, but without a good communication and motivation and creating the personal responsibility, it will not fly. And it's selfish, of course, because we know that the system is going to be, let's say, financially quite tough in coming years. And if we can save money with, let's say, better diagnostics and early diagnostics, then yes, we will do this step also to protect the financial flow, in the healthcare system. And this is the role of the payers, I believe. And as I said, we are going to have a big novelization of the law on public health insurance. And one of the key topics will be this new funds, or let's say the creation of funding schemes, for the payers to be able to motivate and push people for the screenings.
Thank you. Maybe we could switch directly to Slovakia before we go to European level. So, Sonia, so what is your perspective on the challenges, and maybe how do you see the situation which was described in Czech Republic, in Slovakia? Because I heard many similarities from what Deputy Minister said. So, what's your opinion?
Okay, first of all, let me thank you for invitation and introduction. I'm truly honored to be here with you. As Mr. Dvořáček said, there is kind of competition between the countries, especially in Central and Eastern countries. But on the other way, I have to say that we have a really nice cooperation. Whenever we come at the EU meeting or a projects meeting, like last last week we've been in Brussels also with Marek Svoboda. So always we come together because you are our neighbors, our closest partners, and to build up the cooperation on this small Central Eastern European level is very important for us. So, and regarding the Europeans Beating Cancer Plan, it's not only very ambitious document, but as a representative of Slovakia in several working groups, from several expert working groups on cancer in the Europe Commission. So I would say it's also a political commitment to strengthen and mobilize all EU members and EU member states and also associated countries to drive changes in their countries to improve the life for EU citizens. And like we could see from latest data from IARC, the situation regarding cancer incidence and cancer-related mortality is very different or makes many differences across the Europe. And it's mainly in Central and Eastern Europe countries, also regarding clinical care, but also cancer research, as we could see in ANCAN final meeting data last week. So for Slovakia, it's for Czech, and for Slovakia is very important to be part and to participate in numerous actions and initiatives from EBCP that are supported by either EU for Health program or Horizon Europe cancer, Mission on Cancer programs. So Slovakia takes this chance. And there are several projects, for example, for National Cancer Institute on its integral part, National Oncology Institute is a part of random project CRANE that is focusing CRANE Joint Action that is focusing on building an EU network of comprehensive cancer centers within Europe to improve integration of clinical care and research and education within this EU network. And now the consortium is preparing another proposal and to implement the results of the first CRANE project. Another big project that Slovakia is part of is ECHOS project. This is not from EU for Health program, but this is Mission on Cancer program. And it's very important because it's support and coordination and support action that tries to build national cancer mission hubs in each member state. And these hubs will join all stakeholders working in oncology field, not only in care and research, but also to have a good connection with policy dialogues, to focus the attention on cancer issues on national and local, regional, and national levels.
Thank you very much. And we have also with us Radka Maxová, member of the European Parliament. Maybe one question for you, if you can hear us.
Yes, thank you. Good morning.
Good morning and welcome once again. From your perspective, Mrs. Maxová, how can the European Parliament further encourage member states to actively participate and share maybe the best practices in the fight against cancer? What's your opinion or thoughts about this?
Thank you very much for your invitation. It's an honor to be here online with you. And today we gather to address a matter of profound importance, the challenge of cancer, as you said. The numbers are stark. The impact is profound. In 2020, 2.7 million people in the European Union received a cancer diagnosis, and 1.3 million lives were lost due to cancer. Europe, representing just a tenth of the world's population, bears a quarter of global cancer cases. It is really a huge amount of people. This crisis has been further compounded by the COVID-19 pandemic, disrupting cancer care, delaying diagnosis, and affecting access to vital treatments. It has laid bare vulnerabilities in our healthcare systems, underscoring the need for a comprehensive and coordinated strategy to confront cancer head-on. In response to this urgent call, European Union took a decisive step forward through the creation of the European Parliament's Special Committee on Beating Cancer, BECA. Established in June 2020 and concluding its mandate on December 23, 2021. BECA, Special Committee, played, I think, an essential role in formulating a robust EU strategy to combat cancer comprehensively. BECA's role was instrumental in several key areas. Firstly, in the realm of prevention, BECA promoted effective measures at both national and EU levels, addressing various risk factors that contribute to over 40% of preventable cancers. These actions composite behavior-related, biological, environmental, work-related, social, economic, and commercial factors. Secondly, BECA addressed the challenges faced by patients seeking healthcare services and participating in clinical trials in other EU countries. The committee called for legislative reforms to facilitate mobility and access to specialized equipment and care. It advocated for a single set of rules for authorizing and reimbursing from cross-border healthcare. Thirdly, in the face of shortages and the need to make cancer treatments more accessible and affordable at the EU level, BECA strongly advocated for extending joint procurement procedures. This included a focus on rare, pediatric, and novel cancer medicines, diversifying the cancer drugs supply chain, and monitoring shortage. Additionally, efforts were made to create a strategic stockpile of critical cancer medicines. BECA's comprehensive report included recommendations such as guaranteeing the right to be forgotten for EU patients after the end of their cancer treatment. Furthermore, Committee BECA ensured transparency in the pharmaceutical system regarding pricing components and reimbursement criteria. The EU earmarked significant funding of €4 billion to support action addressing cancer, reflecting our determination to make a meaningful impact. The European Union and the European Parliament, through initiatives like the Europeans Beating Cancer Plan and the work of BECA, demonstrated its commitment to address the multifaceted challenges posed by cancer. It is help from our side, from European Union, and now it is up to all of us. Thank you very much.
Thank you, Mrs. Maxova. We hope that at the end of the day, each patient in the European Union will have equal access to care, and hopefully sometimes also even equal access to the innovations, which it's not the situation today, but we'll definitely need to work on that further. I have one interesting question from the Slido. And I think it's for Professor Sloboda. We see the great improvement. How would you rate the region on scale of 1 to 10 versus more developed EU markets, and define the ideal speed to close the gap? So, Professor, would you mind to maybe respond from your perspective on this? You don't have to rate the countries if you don't want to.
No, no, and there is no necessity to rate the countries because there are objective data and you can look on that because each countries are really different, and actually there are existing differences also within the individual countries. So just go to OECD websites and find data which are regarding the reimbursement of the drug, regarding the sources which are used from the national budget for the support of the healthcare. You can go to the International Atomic Energy website. You can find what are the differences between the existing equipments for the radiation therapy between the Eastern and Western Europe. So there are objective data already exists. The rating, it's really different country by country. But the best indicator of these differences is really the incidence and mortality, as I said at the beginning. So to compare one country to other, sometimes in some countries, like for example, the Baltic countries, the digitalization is much more, which is one was the most important precautions for the prerequisites for the challenges for facing the challenges which we have in the healthcare. It's much more faster than we are, for example. But in the Czech Republic, for example, the reimbursement of the innovative drugs which we use for cancer care, it's about the European EU average, which is, I think, we are only one country from the Central and Eastern Europe, which is about the average regarding this reimbursement. So. And how to deal with it, I already said. I think it's that we have really need to implement the EBCP on the local level. Just to be aware, the EBCP itself is just a political commitment, and there are some flagships, 10 flagships, which recommend what should be done on the EU level. And the different countries, they had to implement different flagships in different intensity. Like, for example, the flagships which are related to the cancer prevention. In some countries, it couldn't be a problem. In some countries, they will need the support. And they can use this document, this political document, for improvements in their national cancer control plans. But maybe if I have the time now, I maybe would like to follow what Sonia said, because Sonia, she gave several examples on how we, as a Central European countries, are involved in the joint activities through which we share know-how between the EU states, and that's very important for implementation of the Europe's Beating Cancer Plan. And that's very important. It's important that all Central European countries are involved in such activities. I mean, the coordinating and supporting actions, the CSA action, which are under the Horizon projects, or joint actions which are under the EU4Health projects. And because sometimes we miss on the map of these consortium countries from the Central and Eastern Europe, and that's of course sad if we are not collaborating together with the countries which they have the know-how. And in many cases, the information about these calls are distributed by the ministries of health to the hospital and research organization and in given country. And there is really need, and I argued it, to engage with them. What is important to say is that unfortunately, sometimes we need a co-payment, which is about 10 to 20%, and I would consider that it's very useful that these expenses, this funding, must be provided by the ministries to these institutions which are participating in these joint actions, because otherwise we will not be able to join all the actions which are now under these programs running. So that could be one of the way how we can really deal with this challenge, and how we can move forward to collaborate together and to have the resources to join this consortium.
Thank you very much, Professor Svoboda, for important insights. Before we go to additional questions for the Slido, I have one question for Dr. Chernikova. Maybe can we already see some benefits from these cancer plan initiatives, maybe in Slovakia?
Of course, we could see all over the Europe, but for Slovakia, the incorporation or participation in EBCP action has already brought visible benefits for Slovakia, and one of is that this cooperation and networking inside EU projects has led to the invitation and visit of Simon Oberst, who is director of accreditation and quality and accreditation at OSCI, and in July he came to Slovakia, and we started or we initiate the discussion with representative from cancer centers in Slovakia, with Ministry of Health of the Slovak Republic to build up or set up the first cancer comprehensive center in Slovakia, because it's also the part of flagship number 5 in EBCP that each EU member state will have CCC and connect it into a huge EU network of CCC by the end of 2025. And there are not so many countries in Europe that don't have. Czech has already 2 centers also. So we would like to get some knowledge and good practices from, especially from Masaryk Memorial Cancer Centers, which is very prestigious institute, and try to build up our first CCC in Slovakia.
Thank you. I have one of these Slido questions I think is extremely important, and we have 2 policy representatives here. So maybe if you could answer really quickly. As policy representatives, what would you say to patients' organization representatives presented here? How do you incorporate their needs to policy-making process? So, Mrs. Maxwell, maybe you could start. What is your opinion? How would you respond to the patients' organizations?
I think that patient organizations are very important here on the floor of European Parliament, because we have really often discussion with patient organization from different areas. It is from mental health, cancer beating, rare disease, and so on. And I can't imagine my work without this patient organization. It is really I can say big lobby organization, and they are very useful for us as a politician. And without them, we can't work, we can't write amendments, and so on. They are really important for my and my colleagues' job.
Thank you. Mr. Deputy Minister, what is your thought about this?
I think it was already proved, that we have to work closely with patient groups, and we integrate them in a number of processes at the ministry in the past, and still continues. What really, I can see, and where they really brings a great value is in the evaluation and approval of the new therapies. And that's something, what we implemented in the area of rare disease. But I mean, number of oncology treatment is also rare, so there is a big overlap. And I think, in these 2 years, when we implemented this inclusion of patients, in this process, shows, that this is the right way. And all those doubts, which were there at the beginning, are, let's say, gone. And I believe, this is something, what works well. And, they are the only one who can formulate it, what is missing. Of course, we are not able to fulfill every need, which is there. We will always have to find the balance of what we can pay and what is requested. And oncology is not the separate area. I mean, the responsibility is there for the whole system. But I believe, that, and I already mentioned it, if we will be able to allow the payers to be more active, in the funding of number of things, which are, let's say, now impossible, because every money, in the Czech Republic, from the health insurance needs to be paid only for health care. So the connection is straightforward there. And I believe, that if there is somebody responsible for the setup of the care and about the availability care, and it's the payers in the system, they should get also the patient groups more closely involved, in formulating, what is needed. So again, if we will allow, this funding and cooperation by the payers, we are allowing to have a close partnership between the payers and their responsibility to provide the care and the patient organization. So for us, it will stay, important partner, and I believe, even more important, for future discussion with the payer funds.
Thank you. And Professor Sloboda wanted to react quickly.
Yes, I would like to follow on what my colleague Dvořáček said regarding the cooperation with the patient organizations. And there are two things which are very important. One, and both of them are implemented in the National Cancer Control Program of the Czech Republic. There is one of the four main objectives of our Czech National Cancer Control Plan is a patient-centeredness. So one whole part of the National Control Plan is only about the patient-centeredness. And a part of it is one is indicator. Just let me check it to describe it correctly. And one of the indicator is, for example, establishment and functioning of patient councils in each comprehensive cancer center in the Czech Republic. And the patient councils on the level of the cancer institutes, it's very important, because then we have real feedback from the unmet patient needs. Well, everything what they need is discussed with the management of the cancer centers, and it's immediately solved. So it's something what I would also recommend to do it in other member countries, to really establish patient councils on the ministry levels like we have, and on the level of the cancer institutes.
Thank you very much, Professor Svoboda. There is one specific question on you. If you could really briefly answer that. So, which of the member states' initiatives or activities are so valuable and can be inspiration for you, for us?
Of course, the Czech. What do we do? So, and it's already a best example which was chosen by the European Commission. It was presented on the subgroup of cancer. So just read the National Cancer Control Plan of the Czech Republic, and it's full of inspiration. But no, it's not a sarcasm. It's really true, because the plan was really very well developed, and I'm proud that we have such one. But what I would recommend, what are several challenges from the European Beating Cancer Plan, which we should really support at the national level, using also the European funding and the funding coming from the national resources. The first, what I would recommend to follow from the EBCP is the digital transformation. And the digital transformation of the healthcare can bring really benefit for the whole healthcare sector. And you can find at least 3 or 4 flagships in the European Beating Cancer Plan, which can inspire us regarding the digitalization. For example, Knowledge Center, which will be built for the patient, European Cancer Imaging Initiatives, or the Smart Card for the patient survivors. So the most important, but to be a part of these digitalization activities, is to build electronic health records on the national level. So this is something what we have to do, and it's also not done in the Czech Republic, generally, of course. And another initiatives which has to be implemented from the EBCP on the national level, which I would recommend, are the flagships which are related to the cancer prevention. For example, there is a flagship for increasing the number of population vaccinated against the HPV infection, and increase the number of patients in the screening programs, which was already mentioned by my colleague Dvořáček, and which was also mentioned by the Sonia Černíková, is to create or at least recognize on the national level the national comprehensive cancer centers and to bring it together on national level and connect it to the European level. So there is something what we can implement immediately from the EBCP on the national levels. But of course, as I said at the beginning, use the Czech National Cancer Control Plan. It's also in English. It's available on the website of the Ministry of Health, and you can find many, many inspirations.
Thank you. That was excellent response. If you don't want to use the Slido, we can still manage to have your question here. So if anyone just don't use it and want to ask something, please raise your hand, and the staff will get you the mic. We have only 8 or 9 minutes, and I have one additional question to the academic research. So I think it's very important. So how has academic research on cancer influenced our overall approach to cancer prevention and treatment? So maybe it's for Dr. Černíková, maybe for Professor Svoboda, or maybe for all of you, if you have some comments or remarks on this from your experience, even in the EU level, I don't know. So who would like to respond to this?
Maybe shortly. I mean, because I'm definitely not the one who should start it, but I use the silence. Yeah. What I see, from our perspective, because I mean, we don't have any big basic research in our ground. Yeah. If I will take, okay, we have the one academic institute, the Institute of Organic Chemistry and Biochemistry, closely working, with Gilead and with Novo on some of the projects and building on the previous, successful research issues. But I mean, where we can really, move it quite forward, in our region, it's the academic-driven clinical trials. Mm-hmm. We can really try to find, the extended usage of existing molecule, for pediatric use, for, bigger indication groups of patients and so on. And I see the Czechrian, and I know that the Slovak, also the Slovakian, those association of academic-based, academic-driven clinical trials. That's something where we can move. And when we see, what coming, and I think I saw there some of the questions, on the gene therapies and so on. We have to extend the capacity in our teaching hospitals, in our research centers, to be ready for the individual prepared therapies, to be ready for application of those therapies, to be certified for all those new treatments, actually come. Because to have a reimbursement doesn't mean, the care, the innovation, that kind of treatment could be really applied. And yes, we have a cross-border care, but if you see, the cost and, the connections with all the moving the patient somewhere, we have to really build this at least regional capacity for the future.
Thank you. Does anyone want to react on?
Academic clinical trials or academic-driven clinical trials are kind of challenge because of finding resources and funds for it. It's the major difference between industry-driven clinical trials. But when you wanna, for example, to establish a cancer comprehensive centers, you need to have, Marek will know, 10% of eligible patients going into clinical trials, and you cannot afford it only with industry trials. So you need to support, you need to find the resources, and that's also some dialogues and discussion on EU level, like I talked about EU network of CCC, how we can find resources, how we can support EU member states to build up their clinical trials, academic clinical trials with researchers and basic researchers, Academy of Sciences.
Thank you very much, and thank for all the questions. Since Deputy Minister...
Can I...
Yeah. Oh, okay. I'm sorry, Ms. Maxova.
Really only few words, because on the floor of European Parliament now we have discussion concerning that we don't have enough represented women in research and trials medicine. and we would like to change it. So this is question also for our experts, so that we need to have equality also in research in all of area of medicine, because from experts on the European level we know that women are underrepresented in research. It is not only in cancer but in all medicines. Thank you.
Thank you. And final 30-second remark from Professor Svoboda.
Yeah, it will be very fast, because you really made a very important point regarding the research, because without the generating of knowledge and evidence, we cannot move in any of the area of the EBCP, like the prevention, diagnosis, treatment, and whatever. So just one example, we use the money from the Resilience and Recovery Plan of the Czech Republic to build a National Research Cancer Institute. It's not a new building, it's just a distributed infrastructure. Within this framework, we connected more than 50 already existing scientific workplaces and institutes in the Czech Republic in order to achieve greater effectiveness in the oncology research, which is very important. So that could be one of the examples how we can work with the research.
Thank you. And that was the last remark of our first panel. So thank you, Deputy Minister Jakub Dvořáček. Thank you, Radka Maxová, member of the European Parliament. Thank you, Professor Svoboda, board member of the EU Cancer Mission. And thank you, Dr. Černíková, representative of National Oncology Institute, for the participation. Thank you all for you and for all your questions. We couldn't answer them all, but I think it was a very productive discussion. Thank you very much. So now we can continue with the second part of our meeting and our discussion. Ladies and gentlemen, welcome to today's insightful lecture on the GLOBSEC Health Readiness Index with a special focus on cancer care. We are, and I am also very privileged to have Martin Smatana, a distinguished GLOBSEC fellow, who will share his expert analysis and perspective on the crucial topic, offering valuable insights in the current state and the future directions on cancer care readiness globally. Martin, the floor is yours.
Welcome. So I'll probably move right here so you can see yourself. So hi again, my name is Martin, as you already heard, and I have a bit longer presentation for you, but I speak at very fast pace, so I hope you will be able to catch up. So the security, resilience, and sustainability are core values at GLOBSEC, and for that reason, during COVID pandemics around 2021, we decided to look into what factors made some countries more successful at dealing with COVID in comparison to others. And while we're doing that, we realized that even though most countries have not yet dealt with COVID itself, most countries were about to face another set of challenges and issues such as aging, depleting resources, rise in non-communicable diseases. And let's say the malicious thing about these issues is that in comparison to COVID, where it takes a couple of days for a person to die, these issues tend to be of rather to interest of media and politicians, because it doesn't happen quickly, it is not as acute, it is not as often in media, and hence aging and depleting resources is often not of interest to politicians, and therefore many countries do not tend to build healthcare systems which are ready to face future challenges. So our point was that in order to avoid what happened to several countries, actually most countries during the pandemics, we wanted to create a simple tool that can be used by decision makers to monitor which countries are the best in Europe, to monitor which best practices there are, to monitor the progress, and to see if there is anything that can be learned from others to make sure that any other future challenges are dealt with more efficiently and successfully. So this was the aim of our the tool which we call the Healthcare Readiness Index, which is a simple one composite indicator, which is a one number, let's call it like that, for every country, which ranks countries and measures them and compares them according to a scale from 1 to 100. But the idea media is still that it is a tool which can be used very simply on a yearly basis for all decision makers on media to see how the countries are doing. So originally we started in 2021 with the CE countries only, because these countries were the countries which were most heavily hit with the COVID pandemics. But for this year's edition, we expanded into all countries in Europe, including Norway and Great Britain, because if you want to look into which country is actually the best, we have to look into, of course, countries outside of the CE region. So I split the presentation into 3 bits. The first part is focused on the methodology itself, but very briefly, because you can read about the methodology in detail in the publications. And second bit, I present briefly the results, and in the last bit, I focus on, let's say, interpretation of results and what can we learn from the best, or what can we learn, or what we need to avoid from the worst the countries that we've identified. So when it comes to the index itself, if you want to assess readiness of any countries to face future challenges, you need to start with your current position as actually what is your starting point, what is your current life expectancy, what is your current rate of avoidable mortality, which is something that even though you like or do not like, you cannot avoid, because that's your current starting point, that's where your country is, where your healthcare system currently is. Yes, it is these, let's say, results are a consequence of previous decisions, but this is something that you cannot influence anymore, because unfortunately this is your reality and you have to deal with it. So this is something that is a foundation of any future results. Then if you want to see if you are ready to face anything in the future, you need to look into factors which influence demand and supply for in the future, such as rate of, let's say, investment into innovations, what is the rate of impact of risk factors on health of the population, what is the rate of expenditure on preventive measures, and other factors which are likely to influence both demand and supply of the care, because altogether these 2 points will influence the outcomes of tomorrow, and also influence the way how if a country is ready to face these outcomes and these all issues and situation. We call the first bit readiness today, which is your starting point, and we call the second part of the indicators readiness tomorrow, and all together they create a GlobSec readiness index. So basically we split the work and the indicator into 2 bits, as I said, so readiness today, readiness tomorrow, and we do not have sufficient time to go into all details, but generally speaking, we've analyzed 38 different questions or factors. We can call them indicators of factors that to some extent influence the readiness today and readiness tomorrow perspectives. When you look into the readiness today, it comprises 18 indicators. 7 out of them are cancer related, because it is, well, very similar number when it comes to readiness tomorrow. Out of 20, there's 11 of them, because basically the way how a country is dealing with cancer patient is a very good proxy of the quality of system itself, and for that reason majority of the indicators are actually related to cancer diseases, because if you look into them, we are dealing with things that either cause cancer diseases or can be or create resources to treat them. So basically majority of our indicator is focused on factors which influence also cancer diseases. It is true that not both perspectives are of the same importance. We believe that even a country which is not doing well today with readiness today can significantly improve likelihood of, let's say, more successful management of healthcare system in the future if proper reforms and investments are made in time. And for that reason, we put 75% of weight of the indicator into readiness tomorrow factors, and only 25% into readiness today. As I said at the beginning, the overall score ranks or ranges from 0 to 100. 0 is the country which is least likely to do well in the future. 100 is, of course, the best country. However, results are relative, which means there is not a single country which would have a score of 100, because we add all different indicators into one. I think the best in the 2022 index is score around 78. But basically, the point is the higher the number, the better the result. That's most important. So now I'm moving into the more interesting bit, because this was a bit boring stuff. What are the results? And firstly, I will present the results of the readiness today, then tomorrow, and then the overall results of the entire Europe and Great Britain and Norway. So when we look into readiness today, you can see on the map, and the more blue the color, the better the result. The best country in the Europe, in the region that we were looking into was Norway with score of 83. The worst was Romania with 47, and average score was 66. As you can see, the CE countries did not do so well. The best was Slovenia with 65. The worst, of course, has to be Romania with 47, but the average score is significantly lower with 54 points. Funny enough, if you look into the results of our readiness today and you visually compare it to the level of excess mortality achieved during COVID pandemics, you can see that there is nice correlation, which indicates that the indicators we chose for readiness today actually nicely correlate to real ability of healthcare systems to face currently the issues. So you can see the more white color on the left, the more colorful on the right, which means the lower the results in our readiness today, the worse results when it comes to excess mortality, which nicely correlates that we've chosen the right indicators. When we look into readiness tomorrow, once again, Norway is the best in the region, and Slovenia is the best when it comes to the CE results. Romania is the country which is among the selected one, the worst. If you can look into the average scores, you can see that in comparison to the readiness today, the readiness tomorrow has the lower average score of only 59 when it comes to overall Europe and 53 when it comes to CE results. So when we combine this together, placing greater weight on readiness tomorrow, we get overall results. And as you can see, or probably not because this is very small figure and table, the best country in the region for 2022 was Norway, followed by Sweden, Germany, Denmark and Netherlands, and the worst countries were Romania, Bulgaria, Slovak Republic, Latvia, and to our surprise, Greece, for several reasons which we can discuss then later on. I know that from this figure it is maybe easy to spot the best country, but not to analyze why those countries were the best or why some of the CE countries were the worst. And for that reason, we've created a very simple plot where we've plotted results of readiness tomorrow and readiness today on X and Y axis to create some, let's say, quadrants or some groups of countries with similar results. And since we do not have sufficient time, I just wanted to focus on the worst and the best. So quadrant number 2 and quadrant number 4 countries, and to look into what they have in common. So if it's possible to spot anything that defines them and they share. And actually it was very simple, especially for the worst countries, because when you look into them and look into what is the expenditure on health, whether on average per capita, and in particular when you look into expenditure on preventive measures, you will see that these countries are absolutely worst and lowest amount in terms of spending. They spend on average 1/3 of the best countries. And as you can see, when it comes to overall expenditure, it is roughly 1/3. When it comes to expenditure on preventive measures, the results are even worse. For example, Slovakia spends 13 times less than the average of the 5 best countries when it comes to expenditure on preventive measures. Why it is this case? The reason is because the expenditure on health is perceived as a short-term cost, which means they see it as I need to save money, that's why they don't invest. But as a consequence, they do not have sufficient, let's say, health outcomes. It is hence not surprising if you look into let's say, access to innovative care or other outcomes of healthcare resources. But I like this graph very much, and what it portrays is that we've looked into what is the rate of availability of medicines according to FPR study, and what is the average time of availability of medicine. So how long it takes for a medicine to be included into the list of reimbursed materials. And not surprisingly, you will find the mentioned worst countries from second quadrant in the bottom of this graph, which means the lowest rate of availability of medicines and longest time needed for them to be included in the reimbursement list. So yes, so very poor access to innovation. But generally speaking, yes, it can be argued that most of these countries, like in the indicators presented, you can find these sheets for every single country published in the report. This is just for you to show that basically nearly all of these questions, all of the indicators, these countries are among the worst. There are only some exceptions, for example, when it comes to proportion of tertiary education and some other aspects which can have influence on demand for future, but only to some little extent, and it doesn't affect the overall score. So, on the other hand, when we look into the best countries, we can find 4 or 5 very common traits. First of all, these countries are the countries which spend a lot, and they find public health system as a foundation for basically all they do. So they have a robust healthcare system, which is not obvious only in terms of level of spending or rate of, let's say, preventive measures and screenings, but also in terms of the way how they deal with determinants of health, such as dietary risks, tobacco, alcohol, or physical activity. This is a screenshot from the publication which is called EU Health State. This is a case of Norway. This figure particularly looks into what proportion of deaths can be attributed to one of the risk factors, and Norway, as the best country in our ranking, you can see that in every single indicator they have either the same or significantly below, in most cases, results. So when it comes to dietary risks, average European country can attribute 70% of death to these dietary risks or dietary factors. In Norway, it's only 13. When it comes to tobacco, it's 12 against 17. When it comes to alcohol, it's 3 against 6. Pollution, 1 against 4 persons. So they are significantly below when it comes to management of risk factors. Second factor is that these countries tend to have a nice, let's call it health policy, stability and continuity, which can be measured in terms of how many days an average minister in health stays in function, which is what's average tenure in a function. And when you, for example, look into one of the best countries, such as Germany or Netherlands, you can see that it's above 1,000 days. The lower you go in our ranking, the lower the average tenure is. For example, Slovakia has an average tenure of a minister of 544 days since 2000. But, for example, ever since 2020, so since, well, the pandemic, on average tenure is only 9 months. Why this is important? Because it's very difficult to implement reforms. Implement reforms if you have a new minister every year or every year and a half. And the best countries are the countries which really a minister stays in his position so he can actually not only create a reform but implement it. A good example is Norway once again. For example, in 2018 they've created a specific tool, or let's say, how to call it, a mechanism to support innovative care, such as CARD treatment or several other types of oncological treatment. In 2020, because still was the same minister, they looked into the original idea and they fine-tune it to make sure that the original idea is implemented and they will get the results. So this is something that can be done only if there is a minister who is more than a couple of months, or in our cases, only years. And not surprisingly, when you look into the same figure that we showed before, these countries are in the top of the availability of medicines as well as average time of availability to medicines. So you can see that it actually works. The third and fourth factors are that these countries invest heavily into HR resources. You probably know this graph because most of the countries which are represented here are in the bottom quadrant, but Norway, as you can see, is among the best, including Germany and other countries. And last but not least, it is always about resources and money. These are the countries which do not, let's say, pretend that healthcare is cheap. No, they actually are among the highest spenders, and they are fully aware that you need to invest into people, into health of the people, to get value, to get results back. And for these reasons, these countries tend to perceive investment or expenditure into healthcare as an investment rather than cost. So they are fully aware that they need to invest to get back. This is the graph from 2020 because that was the latest time available for all countries when we were publishing the publication originally, but it didn't change a lot in 2021. Basically, the countries which scored the best in our ranking are also the highest spender, and it is because they know that you actually have to invest, you need to find the resources to get the value from the healthcare back. What's interesting, if you look into details into the spending, because it's not only about, let's say, to have the most innovative medicines available, it is also into investing into type of care which do not deliver from some perspective that much value, such as long-term care or palliative care. But this is what makes this country special, because they realize that even though you are 65, your life is not over, and if you have good care, you can live another 20, 30, maybe even 40 years, and you can deliver still value to the society, to the country itself. And for that reason, they spend not only into prevention of medicines, they spend heavily on long-term care as well. Because what healthcare is about, it is about creating and delivering value. And this is something that these countries are fully aware, and this is, I would say, the baseline of all they do in the healthcare. So this is a very basic introduction to our readiness index. I believe that you have the publication ready, so you can have a look into it into more details. We do not stop here. This is presentation which had only 40 slides, but I have a longer version which has roughly 350. If you are interested, because we have an analysis of most of countries are available, but we will publish another one next year because we want to keep this updated on a yearly basis so policymakers can actually see if there are any differences and if the decisions they make are likely to influence the readiness of their country to face future challenges. So that's all from me. Thank you very much.
Thank you, Martin. Well, I didn't saw the presentation the first time, but always I find something new on it, and it's highly informative, and thank you for your hard work. So it's about the not cost, but investment, about the value. It's about the continuity and stability, which we all always say to our politicians in Slovakia that we need that to be successful. But since we are focusing more on cancer, so when you were analyzing, these indicators, according to your opinion, what are the most critical areas where healthcare system in our region need to improve to enhance maybe the readiness, and efficiency in cancer care?
It depends, because when it comes to, for example, Slovenia and Czech Republic, they are slightly better than the rest. You could also see it in the graph. But basically, I would say that Slovakia and some countries which are more south to us have had bigger issue with access to innovative medicines, which is something that you as a state secretary, I think, successfully helped to improve with the amendment to legislation. So this is one aspect. Second aspect is takes very long time for medicines to get categorized, to be involved into the reimbursement list. Because if you look into the wait times, the more to the south and east you go into Europe, the longer it takes for some reason. Yeah. So these are the countries which do not always have some kind of early access scheme, and that's why they are losing on value. This is so the second bit. And third bit is that the worst countries tend to have the worst result when it comes to determinants of health. So high rate of smoking, consumption of alcohol, sugar, low consumption of fiber, etc. So these are the factors which contribute to a great extent to a slightly above average rate of incidence of cancer diseases.
Yeah, we were discussing the waiting ratios for the new drugs. I think in Slovakia it's around 560. Yeah, and for example, the Germany is 60 days or something like that. To have. I mean, it's not a really big problem to cut it, but once again, we need really the different point of view. That was my question for the Martin. If you have any, I just take a quick look at the Slido. There is no question, so we have room for one more question.
And if you don't like questions, I will be there so you can ask me whatever you want.
Okay. Martin, thank you very much. So now there is the most important part of our meeting, break. I hope you had a refreshing coffee break. And a special welcome also to our online viewers joining us for this crucial segment of our meeting today. As we transition from discussing the EU Beating Cancer Plan, we focus our attention on multiple myeloma, which is a critical area in cancer care, particularly in Central and Eastern Europe and the Baltic countries as well. This region, unfortunately, often lags behind Western European nations in terms of access to innovative treatments. So why multiple myeloma? Well, at least due to two reasons. And first is diagnosis and monitoring multiple myeloma is complex. Unlike many other cancers, there is no single diagnostic test. And multiple myeloma is characterized by a pattern of remission, relapse, and necessitating ongoing monitoring and adjustment in treatment over time. And second reason why multiple myeloma is treatment challenges and advancements. I think that multiple myeloma is the forefront of some notable advancements in cancer treatment, including the use of novel therapies, monoclonal antibodies, and as well as CAR-T cell therapies. The rapid pace of research and development in this area underscores its uniqueness in the field of oncology. And today's meeting is a vital platform for different stakeholders to collaborate, share insights, and devise strategies. And really, our collective goal is to bridge these gaps and ensuring that patients across our region receives the same quality of care as we mentioned in the first panel, and access to the latest advancements in treatment as their counterparts in other parts of Europe. It's my privilege to announce and to welcome second panel. The name of the panel is Can multiple myeloma become a chronic cancer disease or even be cured when treated in optimal way? It's my privilege to welcome Professor Hayek, Head of Department of Hemato-Oncology, the University of Hospital of Ostrava, Professor Bila, Head of the Ward of Multiple Myeloma at the Clinic of Hematology University Clinical Center of Serbia, then Dr. Mikola, welcome, Head of Division, Department of Hematology and Stem Cells Transplantation, Budapest, Hungary, and online participants should be with us. Kate Morgan, welcome. She is the co-chief of executive officer of Myeloma Patient Europe. So welcome, everybody. So we will start with the presentation of Professor Hayek, and after the presentation, we will have short video, and you can still use the Slido for the questions. Professor Hayek, the floor is yours.
Okay, hello to everybody. Thank you for kind introduction. Actually, thank to organizer to be here. It's excellent event. You know, we need to keep pressure. So I was wondering why was myeloma chosen, and maybe just for you as probably myeloma is pioneer in implementation of novel drug to the system, and not even one drug, but in implementation of combination. We used doublet, now currently using the very expensive but very effective triplets, and also starting to use the quadruplets. So it's really challenge even for us, but also for the system, because it's really expensive. So maybe this is a good example and why myeloma is today here. My task today is simply introduce this hematologic malignancy to you. So I will be short, do believe, and simplify the things. This is agenda, starting with epidemiology. And you may know that multiple myeloma is a rare disease. It's comprised close to 2% of all cancer types. And as you can see, there are 36,000 people diagnosed in US and close to 42,000 people diagnosed in EU with new myeloma annually. Okay, this is typically diagnosed later in life. You can see median age of diagnosis 69, and what we know about survival, long-term survival, you can see data almost 10 years ago, close to 60% surviving more than 5 years. And on the right side of slide, you have the data from Czech Republic. Incidence now increase up to 6.6. And as you can see, incredible increment of prevalence, plus 70%. Today, living with this diagnosis, 3,300 people in Czech Republic. And the increase of prevalence is exactly because we have effective treatment and patients survive longer. Okay? So it's significant accumulation of patients which create also issue for the system. What about symptoms and diagnosis? Plasma cells is critical cell. You know definitely that plasma cells produce immunoglobulins which protect us against infection. cancer plasma cells, we call it myeloma cells, also produce immunoglobulin, but this immunoglobulin is non-effective against infection. We call it paraprotein or M protein. So it's critical feature. It's happening in bone marrow, and as you can see, clinical manifestation, it's bone disease. So it's critical manifestation is pain and fracture. We can see it in 70% of all our patients. Of course, there are other major clinical manifestations like anemia, fatigue, hypercalcemia, renal failure, increases the risk of infection. Diagnosis. I will not go through diagnosis criteria, but just I can tell you, if is some suspicion of myeloma, and we thinking this way, it's very easy to do diagnosis for experts. It's really easy. Having said that, in real life, it's significant delay before the myeloma is diagnosed. It's even more than 1 year, and it's critical. And it's exactly because it's a rare disease, and the symptom is quite universal. Pain is universal, you know, pain you can see everywhere. So that's the reason. So what about treatment and prognosis? Just simplifying things. You may know from at the beginning it's some clonal expansion. Okay, then we called this like precancerosis, and it's asymptomatic time. Period is different, patients from patients. But then we move to early myeloma, late myeloma, or even to plasma cell leukemia. In reality, there are cycle of worsenings, we call it relapse or progression, which alternate with remission status. And what is important that with each additional line of the treatment, patients experience rapid progression through available therapies, decreasing responses and poor outcomes. This is only one exclusion. If we use new, modern, very effective treatment, then change the story. So finally, what about future and cure? This is the best of the treatment if we can implement all available drugs currently approved in Europe, which is not the case, even in Czech Republic. In most countries in Europe, it's not the case. Currently, we are usually using 6 up to 8 treatment lines, not so effective, still expensive. So ratio of efficacy and effectiveness is not so good, because we need such treatment move up front, because if we use most effective treatment up front, then we really do the best for our patients. So this is the ideal scenario for currently approved treatments. You can see 10 years course of the disease, just 3 treatment lines, and most important, cure fraction increasing probably up to 25%. It's not enough. You have heard definitely about CAR-T, genetically modified T cells, and bispecific antibody, basically the very similar effective treatment options. So this is modern immunotherapy. We call it now in general hematology like tsunami wave, and it's changed the story in the future. So finally, in the future, it would be probably 10 years course, just 2 treatment lines, cure fraction increase up to 50%. We do believe it's happened. And for our system, and especially for our patients, the important thing that the design of a treatment will be just for fixed duration. So it will be really appreciated with the system, but it's mainly in patients because we create treatment-free window. So conclusion, the development in the last 10 years of new myeloma treatment has greatly improved survival and quality of life for people with myeloma. There are definitely still several unmet need situations in the course of this disease, and there is limited access to modern therapy in this region. That's actually the reason why we are here now. Thank you for attention.
Do konca života nezabudnem na marec 2018, keď vlastne mi pani doktorka oznámila moju diagnózu.
Prvo kad sam čuo multipli mijelom, prvo nisam znao šta je to. Jaz pol, ko mi je zdravnica razlagala, kaj vse me čaka, jaz jo sploh nisem več slišala. Ne?
Meg kell gyógyuljak, mert van 2 kiskorú fiam.
V bistvu se je točno 2. junija 2019, ko sem tuširala svojega sina, pojavila ena zelo pekoča bolečina v spodnjem delu hrbtenice, ki je nekako prešla potem do vratu in do glave.
Ja sam inače puna energije, ali sam bila strašno umorna da sam, što ja znam, nakon 5 minuta nečega što radim, morala sjesti, odmoriti se, nisam imala snage. Počela sam se puno znojiti, što inače za mene nije bilo normalno.
Niin katsomaan, että nešto ozbiljno. Mislio sam proći će, međutim nije prolazilo.
Először a körzeti orvos azt mondta, hogy ez egy izomláz lehet, de azért biztos, ami biztos, elküld egy röntgenre és egy ultrahangra.
Seveda je bil to šok za vse, zato ker sem mlada. Ne? Načeloma je to bolezen starejših ljudi. Jaz pa sem takrat bila stara 37 let in...
Te stvari se događaju nekom drugom. Ali ovaj put sam ja taj neko drugi.
Kako mislite kemoterapija? A hoće to utjecati? Ja želim iduće godine još jedno dijete. Onda došlo to do moje glave. Znači ono sve što ona govori. Ja sam rekla dobro, a mogućnosti života, rekla mi je pa prosjek je nekako 5 do 7 godina. Mislim, ja sam ostala šokirana. Kako mislite 5 do 7 godina?
Nekako mi malo rano da odem, prerano. Ne osjećam se još da je to.
Ja sam rekla, dobro, a recite mi, je li itko ozdravio? Kaže ona, nije nitko. Ostala sam onako gledajući u nju i rekla sam, dobro. Izišla sam na vrata i na vratima sam se okrenula i rekla, dobro, ja ću onda biti prva.
V UKC Maribor so me mogli operirati, ne? Ker meni so mogli najprej rešiti življenje, ker je pač to le kost, ki, če bi me jo tumor še čist do konca požrl, bi umrla, ker bi klecnila z glavo in bi se zadušila. In potem je sledilo zelo težko obsevanje. Imela sem 12 obsevanj, shujšala sem v celotnem obdobju 30 kg.
Nikto vás nepripraví na to, čo vlastne vás čaká.
Teško se prisjetiti svih tih situacija, ali nastojim zapamtiti samo one lijepe, a one koji su teške jednostavno zaboraviti ići dalje.
Mislim, nisam mogao da podignem ni nekoliko kilograma, nisam mogao da podignem, međutim sada zaista onako kad se to poboljšalo, sad radim relativno normalno onako.
Svaki put kad odem na kontrolu, znači profesor je zadivljen sa mojim nalazima, bila sam svjesna, znači svi moji prijatelji koje sam stekla na početku bolesti su umrli. Znači to je vrlo teško, znači ali sam odlučila ja želim živjeti, želim se boriti. Bolest neće upravljati s mojim životom, nego ja ću živjeti s tim. I bolestan čovjek živi. Znači, počnete cijeniti nekakve druge stvari kad se razbolite, vidite da ono što imate, kao što je zdravlje, uopće ne obraćate pažnju zato što ste zdravi. Tek postanete svjesni toga kad izgubite.
Keď mi bolo najhoršie, že úplne som plakala, tak som si spomenula na jednu bajku o 2 myškách, ktoré spadli do kanvy so smotanou. Jedna to vzdala a utopila sa v tej smotane a druhá proste bojovala a toľko trepala nožičkami, až utrepala z tej smotany maslo a vyšla z tej kanvy von. Treba bojovať do poslednej chvíle. Treba.
Mislim, ja preporučujem svima, ne daj Bože ko oboli ili šta znam, znači živite normalno život, ne odustajte, nemojte da vam te misli o bolesti preovladaju u svesti.
Erős harcos vagyok, mindig is nagy küzdő voltam, és most is menni fog, és újra tünetmentes fogok lenni.
So we heard words of pain, but also words of hope. And I have maybe 2 questions for you, Professor. So I know you're running one of the most successful registries in this region, focus on this disease and some others. So according to your opinion, what are the most promising areas of research in multiple myeloma, maybe from your perspective, and which could lead to potential cure in the future?
That's a tough question, to be honest. First, I'm not trying to be provocative, but cure is already here.
Okay.
We're just trying to increase the cure fraction. It's repeatedly copied in the even expert manuscript that this is the uncurable disease. So please, it's curable, but fraction is still limited, and we have and try to increase it. To me, the immunotherapy, especially this new modern immunotherapy, this is probably a research field now already transformed to clinical setting, which is important. For the future, it's very difficult to be focused on something, but probably if we will more understand generally cancerogenesis of this disease, that probably would be some hit which we can attack by new treatment modalities in the future.
Thank you. You can still use the Slido for the questions if you want, or you can raise your hands. And my second question for you is, we look at the patients. Patients will play a big role also on this event after this panel and after several presentations. So how to maybe improve the quality of life in this kind of treatment, especially considering the long-term management? I think you showed us that maybe some steps how to improve that.
Actually, for me are 2-point criticals. First, there is no connection about early diagnosis and prognosis. There is no connection. But there is really strong connection with early diagnosis and quality of life. Why? It's completely different for you if you have 3 vertebral fracture, if you have to receive dialysis twice weekly, which is one of the reasons of delay diagnosis. So this is one point. It's critical. And second to me, and now the dogma and concept of treatment strategy in myeloma finally is changing. We are not more saying probably that we need continuous therapy until progression. Why? Because, in past, when the progression-free survival was 1 year, 2 years, okay, it's worked. Now we have treatment, combination triplets, progression-free survival is 6 years or 5 years. Come on, nobody from patients can accept triplets of strong, intensive treatment combination for 6 years. Usually it takes 10 to no more than 3 years, and then the therapy is generally stopped. So to me, increase the quality of life of our patient is create treatment-free window, which naturally happen because we are using such effective therapy that patients are basically in deep remission, and it's not probably needed other therapy. It's still, negotiated. It's still under investigation, but this is the way when we going.
Mm-hmm. I think this was also partly the answer to the question we saw in the Slido, that in your opinion, what are the key challenges in achieving long-term remission or cure for, we discussed the cure for multiple myeloma. So if you want something to add to the long-term remission, you can, but I think you just mentioned that.
Yeah, I mentioned that it's important for us to have some, evidence-based data. So now still are not finalized that we can stop formally therapy. because, you know, on the one hand, there are still active the treatment which saying basically treatment until progression. But we know that probably 1/3 of our patient is in deep remission, and their perspective is really quite long, more than 10 years. So then we have to discuss with them to stop or not treatment. And it should be decision of patients because, you know, we have to be protected. But generally, new therapy and new clinical trials are already designed for fixed time dose. So that's important.
Thank you very much, Professor. We have also Professor Bila with us. She's the head of the ward of multiple myeloma from Serbia. So, is there a possibility for a cure, Professor?
Well, before I answer your question, I would like to thank the organizer for the most kind invitation to participate today in this meeting. Well, as we heard from the talk of Professor Hayek, tremendous progress has been made for the past 20 years in the treatment of multiple myeloma. Starting from 2000 and introduction of the proteasome inhibitors, then immunomodulatory drugs, up to the 2015 and the immunotherapy, concept of immunotherapy, which completely opened the new era in the treatment of this disease, starting with monoclonal antibodies, bispecific antibodies, up to the CAR T cells. So how to choose and how to bring our patient to the cure, or at least functional cure. Well, from the perspective of the clinician, I can say that one size doesn't fit all. We have to make the individual prognostic profile of the patient, individual clinical profile of the patient in order to provide him the best possible treatment option. Also, there is the importance of the treatment in the first line. So what is the goal? To achieve deep and durable remission and bring the possibility of cure to our patients. Well, the modern therapies also brought us the problem of the economic burden, but with the personalized medicine and the well-chosen therapy approach, I think that that issue can be solved.
Thank you very much, Professor. We have another member of the panel is Dr. Mikala, and I heard that you had a really interesting publication in Hungary, focused on multiple myeloma. Maybe would you mind to share?
I have just prepared one slide, and
Thank you.
It's coming up. Yeah. So what we have done in Hungary is that we compiled an expert of 20 people who are not just myeloma treating physicians, but physical therapists, nurses, patient support group personnel, and we try to identify the most important problems we need to solve to spearhead the progress in the case of multiple myeloma. And on this very blunt spearhead, what you can see here, are the most important things we have to accomplish to get better care. So 6 points were identified. So let's go through them each one by one, just a few seconds to do so. So we have to get better access to therapies, because what Professor Hayek and Bila said, that we can give the best therapy in the first line for the patients, and this will give you a long-term response. This is true for approximately 2/3 of the patients. But unfortunately, maybe a quarter of the patients are high risk and rapidly progressive, and for these patients, we need the best therapy, and unfortunately, they will need a sequence of best therapies to achieve the goal, but for the standard risk patients, less is maybe sufficient. And we need to improve the diagnostic infrastructure, but because, yes, it's true that the early diagnosis does not mean so much for the myeloma patients, but a late diagnosis, as Professor Hayek said, would mean a terrible consequence of long-term dialysis. And what we see in Hungary that especially elderly patients with a late diagnosis, many of them unfortunately die in the first 1 or 2 months of their disease. So that this early mortality could be really handled only if we can identify, especially the elderly patients, a little bit earlier in the disease course. And this is something we have to accomplish with better involvement of the family physicians. And of course, we have to improve the patient care services. That's easy to say, but more difficult to accomplish. Of course, therapeutic guidelines. This is something interesting because in our countries there are guidelines, which are the European guidelines, and we have financial supporting environment, which is not very supporting frequently for the newest guidelines. So what we usually say, we lag behind 3 to 5 years behind the guidelines of the Western European colleagues. So we have to have professional training and to spread the information, especially for neurologists, nephrologists, rheumatologists, and family physicians to think about myeloma earlier to avoid the devastating consequences of the disease that has been discovered late. And of course, last but not least, we have to improve the patient support services and patient care. So these were the main consequences of our study and published hopefully soon.
Thank you very much, Dr. Mikala. So it's about the right treatment, the right patient, right time, yeah?
Yeah, all three are very important.
And then we have Kate Morgan with us. She's representing the patients with myeloma. So why patients in our regions do not have a chance for cure compared to Western countries? What do you think?
Yeah, so I think just to comment on what the other panelists have said, I think over the past 10 years across Europe, we've seen myeloma transform from a life-limiting disease to a more treatable one. And this has largely been because we have access to innovative therapies, but we know that those survival benefits aren't uniform. And I think access to medicines, as you just pointed out, is the main reason for this. And I think Roman touched on this point, is that the cost and the affordability of the myeloma pathway and individual treatments is prohibitively expensive. So patients receive triple, quadruple combinations until progression, and then repeatedly over the course of their disease. And that, for many healthcare systems, is just too expensive. At MPE, we've mapped access across Europe to the 31 European Medicines Agency licensed therapies. And we have the data on search for maps on our Myeloma Access Atlas website. And what we really found is that Western countries, particularly Austria, France, and Germany, have access to nearly all newly licensed therapies, including CAR-T and bispecific antibodies, which are very innovative therapies in myeloma. So doctors in those countries can pick and choose the treatments flexibly. And as the previous speaker was saying, this is really important for sort of high-risk patients and patients who are sort of elderly and frail, because you're not treating them in a one-size-fits-all way. In Central and Eastern Europe, what our data shows is that countries like Slovenia do really well in terms of access. But across the board, we're seeing sort of variable and slow access to medicines, particularly in the newly diagnosed setting, where we have very variable access to the best therapies, which we know is really important for survival outcomes. And when patients relapse, there's often not much choice in terms of appropriate combination treatment to make sure that survival is kind of increased. So I think what we really need to do, and hopefully we'll be discussing this in the breakout session, is to think about how we tackle some of these access issues relating to affordability and cost, because the current system isn't really working for patients. So how do we price medicines appropriately? Are there alternative reimbursement models we could be exploring? And also, how do we work together as a community to sequence and optimize the pathways that we have in place? Because as Roman said, there is potentially the cure is out there. So how do we use the therapies and approve them in a way that enables us to get there? And finally, one last point I wanted to make was that access to clinical trials across Central and Eastern Europe is a big issue in myeloma. We did a report recently which found that only 6% of myeloma global trials over the past 20 years opened in Central and Eastern Europe. And we have superstars in the region like Czech Republic that have really good access to trials, but other countries where we haven't had access to a single trial in 20 years. And the reasons behind this are complex, but generally what we see is the industry open in the big 5 countries in Europe, and they don't open where it's difficult. So if there's difficult regulatory or sort of bureaucratic barriers, and also where reimbursement is unlikely at the end. So this means for Central and Eastern Europe, we're not getting data from trials to support national approvals, and patients aren't benefiting from access. So I think access to medicines and clinical trials is a huge and sort of profound issue in the region that I think it would be great to speak about today and how we address these issues for patients.
Thank you very much, Kate, for the important insights. I think that, for example, the data are important not just for the patients, but also for the regulators to define the best possible strategy for the future. Since we have like 7 minutes left, I have one question for both of you. If you would like to share with us when you look at your countries and in Serbia and Hungary, what have been implemented to improve multiple myeloma treatments and outcomes in Serbia and in Hungary, please, Professor?
How to solve the problem. So I had a slide about the accessibility of the accessibility to new treatment modalities for multiple myeloma in Balkan countries. And you may notice, sadly, that even first line is challenging for almost half of the countries in Balkan region. So how to solve this problem? Well, we have to build very strict regulations in terms, as we said, personalized medicine, as one size doesn't fit all, then right therapy in the right patient, in the right moment. And finally, when we speak about the communication with our patients, it would be like this. Medical doctors has knowledge, should be provided with resources, and the patients have the needs. So together we can find the solution for the best possible option. Also, for the country where I am coming, we have a special legislation allowing us to provide the best possible treatment in high-risk patients. Sadly, less than a quarter of the patients are treated that way. But what I would like to emphasize is that we need more real-world evidence data and studies. We need to work together on this data, registry data. Then we need regional collaborative work on the investigator-initiated trials. And that would be the points that I would like to emphasize.
Totally agree. So more data, valuable data. Yes.
Yes. So what I can see in the last 10, 15 years, the two most important things what we have accomplished is not, of course, we had new drugs, but we also had standard of care now. We can do cytogenetics, and what we can do is minimal residual disease monitoring. Because I think it's important, again, that, of course, everyone said the word that one side doesn't fit all, but we can see myeloma patients who do well with one line of therapy for 5 years. And we can have myeloma patients who have 5 lines of therapy in 3 years and then dies. And for these patients who have the high risk, it's very important to treat them to minimal residual disease negativity. And now we have the means to achieve that and ways to detect it. And we should do that, and we should pursue it diligently. And I think this is something which we can do it now, and we have done it. And now we have to do it more universally, because now all this is available, at least in our country, in the major regional centers and not in the 19 small county hospitals. And I think this is something short-term we can have as a reasonable goal, to have it universally available, these two methodologies. And of course, everything can be built later on this platform.
Thank you very much. Professor, you wanted to add something?
Actually, you know, it's always about money, you know. So you have to talk with regulators, you have to pay, you have to talk with payers. It's always about money. And, you know, if I see the Czech Republic, and it would be generally in many other countries, the system is very conservative. I mean, we need help of some really specialists on pharmacoeconomy to help us to calculate the scenario different way as currently is. Cure is not implemented, and it completely changed scenario. If the 1/4 of patients will be cured with just one line, benefit to budget impact would be incredible. Nobody calculated. Yeah? Then we have some threshold is very low for cost effective. So the advocacy of regulators, we are not approved because threshold, it's above threshold. But in the same time, we know that this regimen is twice more potent, have twice more cure potential than all others, and it's still not approved. So it has to be changed. Probably the models which are used with regulators are 10, 20 years old, and it not reflect reality. And development, so rapid development in this field. That's my suggestion, and I want to encourage all pharmacoeconomists to be focused on.
Yeah, thank you, Professor. As a health economist, we should talk more. Thank you for this insight. And maybe last question for the Kate. Morgan, how can patient advocacy organizations collaborate with healthcare professionals and researchers to enhance the overall care landscape for multiple myeloma?
So I think in terms of collaboration with the clinical community, I think there's a huge potential to work together to identify sort of best practice. And this is something we've discussed with the European Myeloma Network and with stakeholders like Roman, where we have really good examples in Central and Eastern Europe of access to trials, for example, in how do we sort of identify those areas of best practice and make sure that we're able to work with countries that maybe don't have that capacity at present to develop their ability to implement clinical trials, for example. I also think that the conversation today around access and real-world evidence and the challenges that we have in myeloma, I think it's really important to have kind of open and honest discussions about the challenges that we're facing, generating data on sort of access and approvals, and making sure that we collaborate to have a shared voice on how we address some of these issues, because they're really complex and no one has the correct answer. And I think that discussing the challenges is really important. And over the past 10 years, I've seen huge leaps in collaboration between the clinical and patient community. And I think that will only increase. But it shouldn't just be patients and clinicians that collaborate. It should be it should be payers and researchers and other stakeholders to make sure that we're all working in the direction that improves outcomes for patients.
Thank you very much, Kate. And this was the last remark of our panel. So thank you, Professor Hayek, Professor Villa, Dr. Mikala, and Kate Morgan. It's my unusual role to be the moderator, but more usual is to be presenter. So I will continue with my lecture about the Quo Vadis blood cancer. And I will skip several slides right after this one. This is the influence of innovation in numbers. So when we say that we live longer, up to 97, 45% of that longevity belongs to pharmaceutical innovations. From 2000 to 2009, it's about 73% belongs to pharmaceutical innovations. We heard these numbers, but major reasons of early deaths in working age is cancer in all countries around the world. When we look at the economic losses, the 60% belongs to the cancer, and when we look at the small country of Slovakia, our latest research shows that Slovakia has loss in productivity about 680 million in 2009 and 1.2 billion in 2021. So it is a real big problem, you know, the cancer also for the economy. So as J. Grant Howard stated, demands will always exceed resources. It's not possible to fund everything and to have everything. Doing everything is impossible, but doing good is imperative. And as we heard, we have to invest. And investing in innovation in oncology is something which is worthy. You know, this study from UK said after first year, one invest British pound brought back 0.44 British pound just in 1 year. This is excellent. So radiotherapy, $1 investment into the radiotherapy brings back $4 investment in the long term. And when we talk about the productivity, €1 investment brings back €10 investment. You know, so it is worthy really to invest into oncology and in bringing back, you know, the impact and the economic impact, even though it's longer than the 4 years that the one government lost, you know. So we have to change the narrative and say, well, you invest today, but don't expect to have the results in 4 years. Sorry, guys. Yeah, you have to look 5, 10, 15 years. You know? So multiple myeloma, we've done the research at this area since 2017. We started with the direct cost. We found out that from the for early diagnosis to death of the patient, it costs in Slovakia around €400,000. Then we included the indirect cost, and then I would like to present the new data we have from Slovakia. So when we looked at the primary care costs, and in 2014 there were €1.8 million, which were coming from the health insurance companies to treat the patients with the multiple myeloma. And we see almost 5 time increase into 2022. However, when we look at this, it's 30% of the total cost for the multiple myeloma, and it was 10% of total cost in the 2014. So it's dramatically changed, and I will explain later. Drugs, there was only modest increase since 2014, it's 10 years, from €11 million to €13 million, and the percentage of the total spending came down from 65% to 52%, which is also very interesting to see. The inpatient spending, that means hospitalization, to have the patients in the hospital, is the most dramatic decrease I ever seen in any diagnosis. So, and it's continual, I think, since 2017 or 18. So from 3.9 million to 2.7 million, and it was 30% decrease. And if in, in 2014, it was 23% of total costs for the patients, which are coming from the health insurance companies, it was to 10%. So it's very interesting to see. We looked at the indirect costs. So I cannot show you all the results, it's impossible in a few minutes. So you can see it's 42% decrease in number of days spent on the sick leaves with the patients with multiple myeloma. This is the exact number for Slovakia. So from almost 18,000 in 2010 to 10,000 in 2022. Then years of potential life lost. We see the increase, unfortunately, but decrease from 2019. We don't know why. That's why we have to continue with our research for several next years. But we have very good news in years of potential productive life lost. We all know the multiple myeloma is mostly the disease of older people or the people in the retirement, but we saw that more and more percentage of the new patients are coming also from the productive age groups. And we see continual decrease in years of potential productive life lost in multiple myeloma since 2010 or 2009, which is very good news. So, we invest more into diagnostic and we treat better. We can see it in the increase of primary care costs. We can see it in the increase of cost or spends on drugs. These are not the cost, these are the investments. It's normal to invest more and more and more. So the basic policy for each government should be not decide if, but decide how much should we increase the budget for the drugs, for example. And usually it's somewhere between 3 to 7% per year. It doesn't happen in Slovakia yet, but hopefully it will. The leader in cost growth is not drugs. So every politician is talking about drugs. They're so expensive, you know, we don't need them. Are they effective? Are the patients need them, really? You know, yes, they do. And you have to think about it from the perspective of value. The hospitalization costs are falling dramatically. Once again, I didn't see this kind of fall anywhere. So if this will continue to 2030, we will spend on hospitalization in Slovakia around 400,000 euro. Reduced sick leaves cost is excellent news for productivity. Definitely, the life or potential life years of life lost, we have an increase, but decline from 2020, and we don't know why. Is the hit of the new trend, or is there some COVID effect? We don't know. So we'll definitely look into it in the next years. But we have productive life lost, have excellent decline, 23%, even 51% in women, which is something we need to discuss with the specialist and to talk about why the women and why only 6% decline in men. So long-term downward trend, its impact on high quality and comprehensive care as cancer incidence increases. So at the end, what to say is that I think the short-term results suggest that the long-term investment into cancer field will be definitely effective. I'm saying this because there are so many studies that prove this concept. And it will bring benefits in terms of economic returns as well as health returns. Thank you. I ask the moderator if he has any question, Robert. He has not. So, it's my pleasure. Yeah, there is one question. Yeah.
So you explained this very, very understandable. So why cannot all of us explain it to our public health insurance?
What's an interesting question? I mean, first, we try to explain them using the numbers which are from other countries. It didn't work. And right now we are trying to plant the seeds with our local data. I think this is something which they cannot just say, well, this is wrong, because they don't have any other data, and this is the way. If it works more or less, maybe less than more, because there is the politics behind it. And they say, well, this is just drug, this is a multiple myeloma, this is just a small percentage of the patients, but what about the others? What about the hospitals? What about the primary care? Because we have problem everywhere, So why should we? So it takes time to change the narrative. It takes time for them to realize that this is not a cost, but this is a value. And it takes time for them to realize that we need really a long-term investment, which we can be proud of, and we can tell to the patients throughout these 4 years that we invested a lot. You will not see this probably in the next year, but we put solid foundations for the future. But it needs the change in the thinking, and it doesn't happen overnight, to be honest. So it's a really tough job, but we need to be really sticking with it, and show them and talk to them, and explain.
You explained in quite detail where the increase is not coming from. Can you enlighten us about where the increase in cost is coming from? What are the major, where is a problem of increasing cost in myeloma? Is just patient numbers and surviving longer, or what is the basis for the increase in cost?
The critical base for increase is it's more patients and the more costly diagnostics, definitely, because the crucial increase is in primary care settings, so where the patients come first. So this is the one, and of course the drugs. We have more expensive, and we will have more expensive drugs. So if you could see that they account for 30 million euro per year, so which is one of the highest number in Slovakia. So definitely these are three components which are crucial. But we need, and we will not see the decrease in drugs, never. We will not see the decrease in primary care, never, because the diagnostic as well as drugs will be always more expensive, not less expensive. So these are the key components of the key driver of the costs. Okay, thank you very much for your questions, and it's my privilege to give the floor to Gerard from The Economist, and the floor is yours.
Thank you, Prof. Fabella. Hello, my name is Gerard Dunleavy. I'm a manager at the health policy team at Economist Impact, and it's my pleasure to be here today as part of this important conversation. I'm going to walk you through a research program that's currently ongoing that we're doing. The research is supported by Janssen, but it's independently conducted by our team at Economist Impact. And thank you to Janssen and to GlobeSec for organising this event today and to be part of the conversation. Okay, so just a little description of Economist Impact. We are part of the Economist Group. Our sister organisation, or more famous sister, is The Economist magazine, and we're the health policy and research arm within The Economist Group. So what we do is produce evidence-based insights and analysis, and that's combined with the creativity and the amplification capabilities of a media brand to produce deliverables, outputs, reports that deliver world-changing impact, hence the name Economist Impact. So I'm going to walk you through the overview of the research, what we're doing at the moment, and some of the initial results. Some of the results that you're going to hear now were presented earlier. So in a way, I apologize because it will be repetition. It's also good for our team to know we're on the right track, hearing from the prominent experts that we're moving in the right direction. So our research is looking across 10 countries within Central Europe and the Baltics. They're listed up here. And what we're doing with the research program is looking holistically along the care pathway for myeloma and looking for barriers to care, as well as opportunities for improvement, trying to understand the epidemiology, the trends, and then the policies that are impacting both the outcomes for patients and the care that they receive. So it's very important for our research to stay within our editorial guidelines, and with that we don't focus on any specific products, so we're looking very holistically across the pathway. And then I'll mention the stakeholder focus on the next slide. So what we're doing with our research, we've just conducted a literature review. We're also going to have some expert engagement, so we're going to have a 2 to 3 hour expert panel meeting with people virtually from experts across the region. So we want a diverse group, both geographically across the region, but also in terms of the stakeholders. So we want to be speaking to clinicians, leading academics, patient voice, policy experts. And that's very important for our research, to have this multi-stakeholder, diverse perspective and viewpoints. And we'll be doing in-depth one-on-one interviews as well as part of the research. All this will come together in a white paper report, which will be publicly available, open access on our website. And it's going to be a reader-friendly, hopefully engaging white paper report to highlight some of the issues that we find around myeloma and some key opportunities for improvement. So the timeline, we began this research last month. We've just conducted our evidence review and we're presenting it here today, the initial findings. Over the next 2 months, we move into the expert engagement phase. There's plenty of experts that we've heard from today that we'll be reaching out to and hoping that can input into our research. And then we'll be looking to produce a white paper report in March, and then we'll be seeing the organisers of GlobeSec again in May to present and disseminate our research findings there. So again, to give you an overview of the findings that we have so far. It's been mentioned, myeloma is a rare cancer. It can affect any age, but it mostly affects older adults. And it accounts for 10% of all blood cancers and is the second most common blood cancer globally. So looking at the epidemiology for the condition, we can see from the last 30 years from data, so the latest data, which is from 1990 to 2019, that Central and Eastern Europe have age-standardized incident rates above the global average. And there's been an increase of 37 and 42% in the age-standardized incidence rate between 1990 and 2019 in Central and Eastern Europe, respectively. And this increase in the number of patients is related to patients getting population getting older, patients surviving longer, as well as better awareness of the disease and higher rates of diagnosis. So the data that was presented on the last slide is looking across the last 30 years. This is looking forward the next 20 years. So this is the estimated number of new cases of myeloma in the focus study countries between 2020 and 2040. So the red circle is the 2040 data, and we can see for 9 of the 10 countries, it's increasing, and there's significant increases in some countries. So this kind of shows the growing patient volume, the number of new cancer cases, of myeloma cases that there will be in 2040 across the region. And in terms of mortality, it's estimated to increase across the region with really significant increases in Slovenia, Slovakia, Czech Republic. So yeah, it kind of highlights the need for action. And the growing burden that the health systems are going to have to manage. It's been mentioned earlier about awareness and some of the challenges with diagnosing the disease. So that's a key problem. low awareness for patients, but also for healthcare professionals. So this is a study from Myeloma Patients Europe. So it's not Central Eastern European focus, but wider across Europe. And over half of patients waited over 3 months. So they felt their symptoms, but they didn't feel the need to go seek care. And that's the first part of the delay. Then for 21% of patients, they saw 3 or more doctors, specialists, before they actually received their diagnosis. And as we heard earlier about lots of the complications that patients have and when they present with more advanced disease. So from this survey, 9% only were identified or diagnosed with myeloma in the emergency room. So their complications and their disease had advanced that much, and it was only at that point that they were diagnosed with multiple myeloma. This is echoing the point that Kate shared earlier. So there's been over 3,000 trials of myeloma treatment globally over the last 2 decades, but only 6% have included patients from Central and Eastern Europe. And plenty of the panelists have said the important role that is in having that local data to drive better decisions. And as has been highlighted, the economic burden, it's quite a challenge, and a lot of that is related to the complications and the costs of treating those complications. So delays in diagnosis cause patients to present with more severe symptoms and complications, such as fractures, kidney failure, and neurological conditions, by the time they present to a hematologist. And these complications necessitate hospitalization, expensive therapies, prolonged rehabilitation, which results in significant morbidity to the patients, but also huge costs to the patients and to the health system. This data might look familiar, Prof. Babella. This is taken from a poster at ISPOR a few years ago. So I'm in the strange situation of we did identify this research, but it's ongoing, and there's more recent data. But yeah, from that study, the increase in costs and direct medical costs between 2014 and 2019 was from 19 million to 24 million. The same trend was reported from the data from the shorter time period in terms of the percentage of costs declining for pharmaceutical and inpatient care. More data is necessary on the breakdown of these costs, such as the type of diagnostic techniques and the medications prescribed, but it's plausible that the improved diagnostics and earlier treatment have decreased the proportion of spending on the inpatient setting. And going forward, more data is needed with detailed breakdown of these costs, especially to understand the impact of novel agents on disease control, end organ damage, hospitalization. And in addition, and it's great to see that there's indirect costs in that study, so I look forward to speaking to you later and getting more information on that. As has been highlighted, improved therapies have had dramatic improvement for patient outcomes. So the explosion of novel treatments over the last 2 decades has meant that the survival of patients with relapse disease has almost doubled. And that of newly diagnosed patients has increased by about 50% following the introduction of novel agents. And using novel therapies, the median overall survival is approximately 6 years. For patients eligible for stem cell transplants, the 4-year survival rate is over 80%. And for these patients, their overall survival is more than 8 years. And that's something that's critical when patients, not all patients are eligible for a stem cell transplantation, but when they are, it can have a significant impact on the care and the outcomes and the quality of life for the patient. So while there has been this dramatic improvement in treatments and options available, it hasn't been universally shared. The outcomes and the care has not been felt, as we've heard, in this region as much as it potentially could be. So real world evidence has shown significant difference in clinical care for myeloma between Central and Eastern European countries and that of Western Europe. And the mortality rates continue to be higher in Eastern Europe as compared to Western Europe. And these differences, this suggests that the differences are based on the rollout of improvements, that it hasn't been uniform, the rollout and improvements in diagnosis and treatment options between the 2 regions. So delayed diagnosis is costly as patients often present with more advanced diseases. It is complicated and difficult to diagnose patients. Part of the reason for that there is such delayed diagnosis is the non-specific nature of symptoms, the waiting times to see a GP, and specialist evaluation. On transplantation, there is data from 6 countries in the region, and of the patients that were eligible and also recommended to receive the stem cell transplantation, just over half received it. And one of the reasons that was cited for this low transplantation rate was the lack of access to transplantation facility and the workforce to deliver it. Also, in access, another challenge in access to timely care is the drug access and how variable it is across our study countries, with several approved innovative therapies not necessarily readily available to patients. And to summarize, so this is just the initial phase of our research, and the initial findings suggest that the burden of myeloma in the region, both in terms of incidence and mortality, is increasing. As also shared earlier, the economic impact is not well studied, and that's critically important to inform better decisions and truly understand the value of investment in better care. There is a lack of clinical trials in the region due to administrative challenges, a lack of workforce, poor standardization of treatment, and access to different novel agents, which are often the backbone of innovative treatments. And then lastly, the several gaps that are evident across the pathway. So diagnostic delays, they're common, as mentioned, because of the symptoms often mimicking common benign illnesses of the elderly. But also the access to novel treatments and transplantation are low within the region, and that has a negative impact on care. It provides suboptimal care and also lags Western Europe in terms of treatment capacity. Thank you for the opportunity to share that with you.
Thank you, Gerard. Are there any questions for the economist for the preliminary research?
I have just a comment regarding autologous stem cell transplant. So if you really mean on patients who are eligible for autologous stem cell transplantation, for example, in Croatia, over 90% of patients who are eligible actually do procedures. So I don't know where these data are from. So I think it is the similar in Czech Republic, even in Slovakia. So.
Okay, no, thank you for saying. This is the initial part, so we do need to speak to experts, get additional information. This was from a published study, but we will definitely double check. But it also highlights perhaps the variation in some countries not having it. Yep.
Again, for the same patient eligible for autologous transplant and receiving it in the first line or in general. I think that's, again, a point where some of the statistics may mislead you, because many patients who are eligible for the transplantation do not receive it in the first line, but rather receive it in the second or third line, and that will skew your statistics. So the patients elect to do it later.
I think that the interpretation is misleading, because the population eligible for the autologous stem cell transplant makes around 40%. So from those percentage, so I think that the interpretation...
Yes, exactly. Yes. It's definitely of the eligible patients. But this is definitely a topic. I look forward to recruiting you for an interview and discussing this in more detail.
You definitely should do that, yeah. And thank you very much, Gerard. I mean, it's excellent work, but we definitely looking forward for the final report, and we are here to help. So, thank you. And my vision for multiple myeloma patient care across CEE. I would like to ask Mira Armour to present her presentation.
Thank you very much first to the organizers to inviting me personally. I'm here actually as a collective voice of patients in Southeast Europe. There are patients here and patient advocates from Europe, some of the European countries. So I'm MYELOMA, I'm an economist, and I also have an impact on my memory the moment when my sister from Zagreb called me in London, where I was working and living, to tell me mum has plasmacytoma. That was in 2000. So in that period, I very quickly learned that it's not actually what my mum was getting in Croatia, wasn't what patients were getting in UK. And then being economist, didn't know anything about how medicine gets onto the reimbursement list. So I had to learn. It was slow, maybe too slow for my mum. But in 2011, when mum died, my siblings and I founded with some doctors, founded a charity, MYELOMA Croatia. And now we support patients in Croatia, but also in the region where actually in some of the countries in CE region, even generic drugs, which are 20 years old, are not available as they are needed. There are limitations in numbers. So that's a bit of an introduction so that maybe you understand why I'm here. Why am I giving this my vision? It comes from carer, becomes patient advocate, and now I'm I'm CEO of MYELOMA. And I've been working in this for the last 8 years full time. So, what lies under our skin? So you saw you saw a film with patients telling about moments of diagnosis. We don't know what is there. Like Ivan said, it happens to someone else, but not me. And very soon, when you get this diagnosis, you sort of go to doctor to Google, you find this and that, and then you go to your doctor with a hope. And then suddenly you realize something is not right, the system doesn't work. So I want to share words of some of my peers or colleagues or friends. One of them is Aldo Delcon, Canadian. He was diagnosed, he said, "Do you recall the day you heard the words, you have myeloma?" I vividly recall that day in 2002 when I was told that I had an incurable disease I had never heard of and that I had 3 to 5 years to live. I remember being overwhelmed by feelings of fear, panic, dread. And above all, the feeling of aloneness. And I think that could be, if it happens to anyone, you or loved one, you can sort of empathize. What is it like? And then we have Marin from Dalmatia, Split. He said he couldn't eat, breathe, or think for days when he had his diagnosis. And then a granddaughter, Anna Maria, who said, "Suddenly I realized I don't have that much time with a loved person." And that's quite profound. So almost everything is to do with access. Actually, Professor Hajic said, no, everything is to do with money. So, because access comes to money. Snezhana is a mathematician, and she said something in 2017 which stayed with me. She lived in Zagreb, and she said she dreads the day, she lives in permanent fear that they will find a drug and she won't be able to get to it or she won't be able to afford it. So she will die. She had allo transplant, quite a dreadful treatment, and she survived the treatment. Anna Rukavina, a young journalist, very talented, who at the moment where she needed help and she needed donation to get funding for the treatment not available in Croatia. And she said, "I trust my doctors implicitly. However, I know where I live. So I ask you more politely to help me." So I think it's down to all of us here. I think one of the panelists said earlier, it's down to all of us to change. The system is not working. We live in EU. Why are we having this country and postcode lottery, with health? We need to stop being saying one word and living different principles. So let me share with you my belief in what needs to happen, because I've been working with patients in Croatia where we are quite well off. Here is our Dr. Sandra Kinda, who with my organization helped to change the things, and we are extremely grateful to all her team. So here's my belief and some of the things. So I made a table. On the left, it's about the disease. On the right is what I believe we need. So it's not an exhaustive list. So I said multiple myeloma is not curable, and Professor Hajek said it is, but it was only up to 30%. When it comes to 70% curable, I'll be happy to say it's curable. So it's not curable, and so we need equal partnership between all involved in creating some sort of plan, and it has to be a treatment plan and survival plan, because this disease stays with you for life. Even if you are sort of cured, you have this fear, oh my God, I've got a backache. Is that a sign? So it's not preventable, we know that, so we need awareness campaigns, and we were very successful with that in Croatia, thanks to Dr. Kinda as well being involved very much. We increased the prevalence in Croatia in a few years from 800 approximately to 1,300 in, I don't know whether it's 2021. It's a complex disease with many facets, so we need specialists, we need doctors who really treat myeloma and understand, they cook this dish, which is myeloma. And as Professor Bila said as well, it needs individualized sort of approach. So we need access to centers of excellence and up-to-date diagnostics. Myeloma is often confused with the signs and symptoms of aging and lifestyle. That happened to Ivan. He had a backache. He's 43 at the time. He went on a holiday with the family. His wife was pregnant 6 months, had a backache, came back to Zagreb, and a friend, radiologist, said, oh, go and do MRI. And they looked at the scan, and they said, go to hematology immediately. Within 2 weeks, he was on a support machine. He had almost dialysis. He lost 9 centimeters of height in the period. So we need education in primary and secondary care, readiness to get and to give second opinion. And you need specialists. We need really, really good knowledge and well-trained doctors. It's recurring, and it becomes unresponsive to treatments, so we need equitable and timely diagnosis and access to optimal treatment and clinical trials. We heard about it a lot, actually. Lots of these things are overlapping, which I'm pleased that we all agree. It's often debilitating, affecting mobility. We need more flexibility in where patients get their treatments. We need more home treatments, which they have in France, for instance, and even in UK with bortezomib. It's life-threatening with possible renal failure, so we need a long-term care plan. Again, access to multidisciplinary teams. It's a cancer of the immune system, so we need a good standard of supportive care. So it affects all aspects of patient life, so we need a really good personal care, support plan, and that's from the moment of diagnosis to the end of life, hopefully a long one. It changes dynamic in, if we didn't have family life, you can imagine Jelena and Ivan, the baby got born 3 months after diagnosis, it was COVID, he had transplant. Children go, the little 4-year-old goes to the nursery, he comes back with all sorts of bugs, dad can't walk, I mean, a nightmare. And it's very financially toxic. And in countries where you don't have access to a first line of these treatments like PIs, proteasome inhibitors, patients travel from country to country to buy it. The patient's families travel, so it's a huge burden. not to talk about the second generation of novel treatments. So we need data on out-of-pocket costs and the cost to society, which Dr. Babela talked about. And above all, you know, when you have this knowledge that your hematologist has no tools to treat you, and creates real despair and fear and anxiety. And we need to give our doctors tools if we want them to treat us. And we need to accept professional EHA, ESMO, IMWG guidelines. We don't need special national guidelines for second-class citizens of Europe so that they can be treated with second-class or very old treatments. So multiple myeloma is becoming more and more treatable. Jelena here, who was pregnant when her husband got diagnosis, 6 months pregnant, she's saying, but we have so much more to experience and do. And thank God, 3 years on, this was this summer, they were on a family holiday. My key messages are that, and I see them as key messages of all the patients and family members that I speak to every day. We are at the crossroads of multiple myeloma treatment with huge advances in treatment, where some patients can be considered cured. And we need to offer, first of all, we need to offer them support. They shouldn't be feeling alone or excluded in the decision on their care plan. And we need early diagnosis, and not that early diagnosis in a way that it would give you better prognosis, but it will stop, prevent sort of damage to your vital organs, like your skeleton, which holds you up, and your kidneys, which are very essential for a good quality of life. And then we have loads of things on access, which we need, and we need equitable access to optimal treatment currently known, and in the earliest lines of treatment. We need access to clinical trials whilst we are waiting for the cure, because multiple myeloma is a marathon. You need to stay alive till the next better medicine comes, or the cure is found, or maybe it's already found, we don't know. And we need transparency, we need accountability of our reimbursement agencies and the decisions they are making. We need HTA, but maybe not in every country. We can have European HTA, we can have, you know, HTA is HTA, you know it's working or it's not working. It's better than standard care or not. We need to consider the whole cost to the society and not be using the best, and we need to be using the best possible treatment in the first lines of treatment, and we need good data, we need registries, we need investment in infrastructure in our hospital, and we need diagnostics, and we need all key players to collaborate, and really it has to be from the top. You can't expect small countries to solve the problem where we know that the system of pricing is actually quite unfair to the small countries, to low-income countries. By the time that the drugs come from actually west to the east, unlike sun, it goes around the world in 24 hours. Drugs go half the world in about 5 to 10 years, roughly, in some countries, which is really, really sad. So our vision is for equitable and timely diagnosis and access to optimal myeloma treatment, care, and clinical trials for every patient in EU, not for every patient in CEE. We are not second-class citizens. We do need somehow to collaborate, and if we really care about patients, and if we really are meaning what we are saying, that the patients are at the center of everything we do, then actually we need to find a way to collaborate, way to find a compromise so that every patient should have all the support necessary. We are hoping actually, and no pressure and burden on you, Gerard, that with your data and review and white paper, we will have a foundation we can work on and change this, and change it quick, because among us here there are patients who have struggled to get the best, thanks to involvement of doctors or all sorts of patients' organizations. So let's support them. Let's work together on this. And just my last words, only for today, I hope. Treatment is more than just the medicine. So let's be kind, inclusive, talk, and let's make sure that the patients believe that they are heard and that they are involved in they understand their treatment plan and their sort of, they can plan their life. Thank you very much. Thank you.
Thank you, Mrs. Armour, for the excellent presentation. Yeah, this is yours.
Oh, that's mine.
Don't keep it. Okay. So, do we have any questions for the Armour? If not, you already started my final remarks.
Oh, did I?
So if I can ask the technicians to go back to her presentations and maybe fifth or sixth slide from the end, because I will use your slide.
That's fine, lovely. I'm pleased.
This one. So when I was preparing for my final remarks, I thought this slide covered everything what I wanted to say. So thank you very much.
Yeah, I'm very pleased. Thank you very much.
And it's important. It's important to really collaborate and to find synergies. The second thing for me is to really take the narrative and keep the narrative in our hands. We are the people who actually know the disease and could talk about the disease and must take the narrative into our own hands. And then we have to be persistent. The change doesn't come over the night. It takes 10, 15 years. Sometimes we were talking about this during the break. We have to be consistent and wait for the moment when the right person in the right time and the right ministry will come and then make a change. So don't lose hope and collaborate. Let's work together. And finally, thank you very much for your attention. Thank you for being here. Hopefully you will take something useful for you, for your work and for your future endeavors and future cooperation. Thank you.